So I thought this would be useful to just talk about how to manage shoulder pain after someone has a stroke. And I'm doing this for a couple of reasons. For one, you have the resource in Umphred, which I think is quite good, on page 352 and 353. Excuse me. And what I like about it is it just provides some real solid interventions that can be used that have had some efficacy and some evidence to support them. It's a little bit all over the map in terms of what works best. I think the individualized approach is highly important, that you don't provide the same intervention to address shoulder pain for every patient. Just as there's different causes of shoulder pain following someone who's had a stroke or has a stroke as a health condition, so too the interventions need to be specific for whatever the problem is at that particular patient. So Umphred, and if you want to just follow along on page 352, really talks about the concept of supporting the upper extremity. We do know that gravity is heavy. Gravity pulls things down. And if you don't have a lot of good muscle strength, tendon strength, it can hurt. It can hurt. So not having support, keeping that the humerus and the labrum, not supporting that socket, can cause these micro tears, which can cause nociceptor pain. So supporting the arm, cradling the arm, a lap tray can be effective. It really is finding whatever it is to best meet the needs of that patient to decrease pain. Now, at the same token, it varies. So if somebody does have some muscle of support, you definitely don't want to go ahead and just say, this is it. You're going to be in a sling, and that's going to be all we can offer you. Now, there has been some discussion that pulleys are not the best approach, that certainly some passive range of motion or some passive assisted activities in terms of movement have been shown to be helpful. Some muscle strengthening activities appropriate for someone that does have 3 great strength or 2+ can be shown to be useful. Some gravity eliminated motion activities have been shown to be useful. It really needs to be individualized. NMES has been shown to can be helpful for someone who does have some muscle activation. Even as low as, like, for example, a 1 can help perhaps improve that muscle strength to a 2 to allow that person to move that arm in a gravity eliminated position. Taping has been shown to be helpful to support that joint. You certainly want to be cautious of skin integrity, but it has been shown to be efficacious in some instances. I wanted to just show you a couple of articles. I did look in PT Now, and there was no article that I felt was really supportive of addressing shoulder pain. In fact, I couldn't really find an article. I couldn't find an article that was real specific to shoulder pain post-stroke. So I did find a couple of resources online doing a web search. This one is a 2006 article, and this is from the British Health Authority. Great Britain, like most European countries and North American countries for that matter, has kind of a universal health care, and so as a result of that, they are able to really, I think, put together some really interesting studies, because they can just gather that information more easily because of people receiving care under one system. So this one looked at 416 subjects. Now there is some reasons that some of the subjects weren't able to complete the study, mortality being one of them. But I thought what was good was just to look at some of the interventions that were done that have been shown to be efficacious. But I think it's a good article, and you can see the link up here if you wanted to copy and paste it and review it. So it talked about strategies, brought up the range of motion concept that we talked about, preventing subluxation, stim. So it mirrors what Umphred is saying, which I think is really good. So I thought that was good to see that in this study. And then this other one is from the British Medical Journal. It's an older article, but it also just comes up with, it really has I think, just a really good evidence-based approach to how to address shoulder pain. Again, it's an older article from around 1990. But what I really liked is it talks about handling, and if a joint is pulled on, or extremity is pulled on, in this case, it can cause shoulder pain and cause subluxation and great stress to the vulnerable shoulder. So caregiver training is really, really important, especially during those crucial months when weakness exists, and it can be years. So I thought this was very fascinating to me, or important to talk about, was that 63% of patients develop shoulder pain in the first 6 months after their stroke. That's a really high number in this study. And it does talk about some benefit with strapping or support. But it really emphasized that if you just put someone in a sling, you really can put them at risk for a contracture. And then you have the overall body image too of how does it feel like the patient just to have your arm in a sling all the time. And it really talked about the risk of shoulder pain with use of pulleys. I thought that was really good and highlighted here. Again, an older study, but I think it really is a solid study when you look at the method that was used. And then it brings up the Bobath approach. It mentions that, and then it talks about TENS use and the benefits of TENS use. Very satisfactory results. And then using a functional e-stim as another way. And the statistics quite vary, 16 to 72%. So we don't have a real solid number there, but we know it's people who've had strokes are at risk to having shoulder pain. So it's an additional resource for you on this topic of shoulder pain post CVA. And what I like about this study is that it looks at other studies. So it doesn't necessarily, so it's one of those higher evidence-based articles, because it just is a combination of looking at several other studies to come to its own conclusions. So a high level of evidence in this study, or this evidence-based article.